everybody. I'm Dr. Swaraj Bhattacharya, General Secretary of the EIZOC, and greetings from the EIZOC Secretariat. We are here again together for being a part of the webinar, Ophthalmology Resident Training Series 9, Part 2. It is giving us a platform for the young generation to come up with the academic activities, and as a whole, this type of programs improves the bond between the states of the EIZOC. Through EIZOC, Eastern India is gaining its position and repute in the National Ophthalmic Forum. Our Chairman Scientific Committee, Dr. Sabyasachi Patnaik, has framed the webinar in a meticulous way, supported by the Chief Coordinator, Dr. B.N. Subudhi Sir, and the Coordinator, Dr. Ashok Nanda and Dr. Anurag Mishra. The program is mentored by none other than our past President of AIOS, Dr. Ajit Babu Majhi. The speaker of the evening is Dr. G.R. Reddy, is a stalwart of glaucoma from Andhra Pradesh. And we had our panelists, namely the Dr. Shahino Tayab, Dr. Prafulla Sharma, Dr. Amar Kanti Chakma, Dr. Maitri Das, and Dr. Deepak Chaudhary. They are very much expert in their respective fields. And we have discussants, mostly are the postgraduate students from different parts of the India. And over to our president, if he's here. President, sir.
President is not joined, I think.
Okay, sir. Then over to our chief coordinator, Dr. B.N.R. Subudhi, sir, for continuation of the program.
Okay, thank you. Thank you, Swaraj. I think we don't need any introduction. We don't need anything today. Already it has been the continuation of the.
Better to go ahead straight.
Continuation of the last webinar. So Dr. B.N. Gupta joined, I think. Our president joined. Let us wait for 1 minute. President, sir.
Yes, sir. Good evening.
Sir, good evening. We are starting the program. Just
yes.
Say hello to everybody.
Yes. Good evening, everybody. We are going to start the second part of this talk, this webinar on automated perimetry. First of all, I welcome the speaker, Dr. G.R. Reddy, who very nicely described the nitty-gritty of this automated perimetry last time. The mentor, Dr. Ajit Babu, Chief Coordinator, Dr. Subudhi, Chairman Scientific Committee, Dr. Sabyasachi, Secretary, Dr. Swaraj, all the panelists, moderators, PGTs, and last but not the least, all the members who are participating in this webinar. I welcome everybody. And I think this time, on the request of our Chief Coordinator, Dr. Subudhi, all the PGTs have come prepared, and I'm sure they will be immensely benefited by it. So make it interactive rather than just the lecture, the edited lecture. So with all these words, I welcome everybody, and I request the Chief Coordinator to start the process. Thank you.
Thank you. Thank you, President. Thank you, Secretary. Thank you, CSC. I don't think there is any, introductory remarks for the speaker and mentors, everything. So let us go over to the second part of our webinar. Today is the automated perimetry. First part is completed by Dr. G.R. Reddy. I know everybody knows him. So it's over to Dr. G.R. Reddy for the second part.
Okay. Thank you all. Now today we'll be covering the second part. Now, suppose if a patient develops a scotoma, normally a scotoma in the upper nasal field defect, we'll be covering this area. And if he develops the field defect here due to the lower temporal retina fibers involved, then this area he will not be seen. And take for example, and if this eye, left eye is open, and this scotoma will be seen here, this area will be seen by this area, and he will not be having any field defect in the field of vision. But when he closes the eye, he will have a scotoma here. And the most important part is the other eye develops a scotoma in the the lower temporal region producing this scotoma, then he will be having the absolute scotoma here in this area. So now the most important thing is, while evaluating the visual fields, if you have a field defect in one eye, you should always see that which area will be corresponding to have a scotoma, absolute scotoma, and if the other eye is developing a field defect here due to these fibers involved, and then means the other eye, the IOP should be reduced. The target IOP must be at a lower level so that to save this field of vision. So the importance is not only identifying the one eye scotoma and the corresponding scotoma in the other eye also you should look for. And a little regarding the fibers involved, the fundamentals. Suppose I will be telling about the superior temporal nasal fibers. The superior temporal fibers will be entering here. The inferior temporal fibers will be entering between the disc between 8 o'clock, 6 o'clock to 8 o'clock. The central fibers will be entering the disc between 10 and 8 o'clock. And the upper nasal, superior nasal fibers will be entering between 2 and 12. The inferior nasal will be entering between 4 and 6. And the nasal fibers will be entering here. This is the distribution of the axonal ganglion cell axons in the disc. And if this layer, if there is any field defect because of this, now we'll be telling about the field defects. The upper temporal superior nasal fibers are involved. It will be involving the temporal this area, and this area is involved due to the lower temporal, inferior temporal. And if the field defect seen in the central, that means the central fibers are temporal fibers causing this central field defect. And any field defect, this is if these fibers are involved producing this area field defect. And if these fibers are involved, this area is involved, and if the nasal fibers are involved, this is the field defect. So this is the field defect. Usually we see the field defects 2 and 6 in PYAGs, 1 to 6 in NTGs. And if you see central fibers are involved, when these fibers are involved, the central fibers will be there. And usually the 3 and 5, usually they are due to the retinal disorders, and 1 and 4 due to the non-glaucomatous field defects. This is the distribution and the area of field defects, and we should also know the distribution of the axons, how they are distributed. Now you know that, how they enter into the disc. Normally the peripheral fibers will enter the edge of the outer edge of the rim, and they are also deep. As the fibers are coming to the center, they will be entering. The central fibers will be occupying this area. The mid-central fibers are occupying this area in the rim. So the edge will be the peripheral fibers. The innermost area, border of the rim will be occupied by the most central fibers. This is a very important regarding the evaluation of the disc. And if you see, as you know, in the center, it is a multi-layered layers, ganglion cell, this thing, should to produce a scotoma. If you see a scotoma in the central area, that means there are almost one black square, 230 ganglion cell with size 3 should be lost to produce a scotoma. If this is a point, this is a 9-degree point, there should be a 35 ganglion cell death for size 3 to produce a scotoma here. As it goes to the periphery, there is only 10 cell ganglions that is required to have a scotoma here. This slide gives you, that means a scotoma in the central degree, if you appears, that means already a lot of damage has occurred, and the target IOP should be kept at a lower level. Regarding the disc evaluation, the most important clinical observation ISN, this is the rim evaluation, and the ISNT rule is the most important clinical observation in the field of ophthalmology. The rim, the inferior rim is more than superior, and superior more than nasal, nasal more than temporal. This observation is very, very important, and violating this rule, you should always think of glaucoma and start evaluating. Most of the 60% of the times you appear to be glaucoma patient will have this, and 40% still they can be normal. Even they are violating, still it can be normal. That is actually ISNT rule. And if you coming to the rim, it is actually evaluation of the rim. And there is a thinning, generalized thinning will be there like this, or a localized thinning with a notch, and may be associated with the nerve fibular defect. And the nerve fibular defect will be more appreciated in the red free light. Because once, unless otherwise you evaluate the disc properly, we cannot pick up glaucoma and we are likely to miss. Because in most of the cases, we see normal IOP, and when there is a normal IOP, you don't spend much time to evaluate the disc. But whenever there is a risk factor, you should always evaluate the disc properly. The original conventional concept is glaucoma starts at this periphery and reaches the center, and that is the usual concept. And when the glaucoma starts from the center, from the periphery and involving the center, the disc looks more pale and will have the loss of rim, and it appears like advanced glaucoma. But we are seeing nowadays, actually, the glaucoma can start here in the center, and you see this 24-2, the peripheral retina is almost healthy. When we see the 10-2, the almost 10-2, the quadrant is involved. So the glaucoma here, glaucoma started in the center and involving so much loss in the central 10 degrees. And if you see the disc between these two, this is looking like more pink and not looking like advanced. So with this concept, the conventional concept, and with the glaucoma starting within 10 degrees, what I thought is, in order to not to miss any glaucoma, if you can start classifying glaucomas on the basis of where the glaucoma field effect starts. If they start at the periphery, outside 10 degrees, type 1, within 10 degrees, type 2, and both simultaneously, glaucoma starting outside 10 degrees and within 10 degrees, that is the type 3. On this basis, whenever you evaluate the visual field, you please keep in mind these three types of glaucomas, and I will be telling, I will be discussing on this basis. So where glaucoma suspects are some 6 cases, 3 cases when they involve outside the center and involving the central area, and purely the glaucomas appearing within 10 degrees. I will be telling about 3 cases, and I will be telling the glaucoma starting both within and outside 10 degrees, 3 cases. As I told you, the last visit, the single field analysis printout, the patient data, test data, and the reliability data. This is the raw data absolute, the measured retinal sensitivity, without any statistical evidence and backing. Directly it is converted into shades, and with the normative data analysis, we will have the total deviation zones and the pattern deviation zones and the global indices and global filtration gaze tracking. And now we will be, this is the understanding of single field analysis printout. Coming to the, you must be well versed. If I say that what is the point pattern, immediately your eye should go this area. This tells you where the point pattern. If I say what is the strategy, you should directly go to this place where the strategy is theta standard. If I say what is the pupil size, immediately you should go to the pupil size. If I say what is the which eye, immediately the eye will show this is the right eye. So, and what is the false positives? If I say that immediately your eye should go to this area. So it is very, very important to be well versed with the single field analysis printout. You should immediately, the minute I say what is the strategy, immediately you should say theta standard. Like that, you must be well versed with the single field analysis printout. Coming to the interpretation. Interpretation of the single field analysis printout depends on at what stage of glaucoma we are interpreting the field. If it is a glaucoma suspect, our aim is diagnosing. In established case of glaucoma, already established, there is no need for, it is already, our aim is to set the target IOP. How the fields will help us to set the target IOP, to arrest the progression and to arrest the new onset of field effects. In advanced case of glaucoma, our aim is to see that the remaining field of vision should be retained throughout his life. And progression analysis, we can have an overview printout, that is event analysis, and glaucoma guided progression analysis on the basis of VFI, that is trend analysis. So whenever you visual field analysis, it should always be correlated with the fundus. This is the most fundamental thing. Without seeing the disc, you should not evaluate the visual field, say single printout. This is the most important basic thing. And one should know, I already told you what is Anderson's criteria, because Anderson's criteria is very useful in a suspected case of glaucoma. The Anderson's criteria should be fulfilled. It is actually to pick up early, the Anderson's criteria is to pick up early localized scotoma. Very early localized scotoma, this means this scotoma, if you take 30-2, you don't consider outer set of points. In 24-2, this is the field defect. Usually the field defect, 3 cluster points in the area usually where glaucoma is produced, and 2 points will have a p-value less than 5%, and 1 point will have less than 1%. This is the field defect. Whenever there is a localized field defect, usually we know that the PSD will be abnormal and GHT will be abnormal. So PSD will be less than 5%, and GHT outside normal limits. If these 3 things are fulfilled, we can say that this field defect can be considered as glaucomatous. This is the Anderson's criteria. So whenever a glaucoma suspect, you always see that whether these 3 points are fulfilled or not. So Anderson's criteria is an index only to pick up early localized glaucoma. So now we come to the interpretation of, and most important, whenever in a glaucoma suspect, always eliminate artifacts and concentrate on these points. It should be either 24- or 30-2, and it should be SETA standard. The reliability indices should be 100% perfect. False positives, false negatives, fixation losses should be 100% perfect. And what is, you may ask, what is the normal range to accept visual fields? So in established case, you can accept the reliability factors up to 15%, especially false positives, and false negatives up to 20%. But in a suspected case, it should be 100% perfect. And it should fulfill Anderson's criteria. So now I will be presenting a glaucoma suspect case. What do you mean by glaucoma suspect? Because there is no evidence from the disc to say there is no ISLT rule violating, there is no notch, there is no RNFL defect, looking like normal, and associated with risk factors, maybe raised pressure, maybe strong family history, pseudoexfoliation, myope. If there is a strong suspicion, and when I associated one of these or 1 or 2 things what I told you, raised IOP or strong family history, then we suspect glaucoma and we ask for visual fields. Here, another thing, cup CD ratio of both eyes. They are not, there is difference in CD ratio of the both eyes. That is one of the factors to suspect glaucoma. In this case, the glaucoma is suspected on the basis of strong family history, IOP around 20. Whenever I say IOP, it is always corrected IOP. And there is a difference in CD ratio. Whenever there is a difference in CD ratio, always consider the size of the disc and say that there is a difference in CD ratio. And this patient actually came with this type of field and diagnosed as glaucoma. I showed you the last time. Well done, very well done field, and having and fulfilling Anderson's criteria. This localized scotoma is fulfilling the Anderson's criteria. PSD is here less than 5%, 0.5%. Glaucoma ME field test is outside normal limits, and the patient actually kept on treatment. But when you see, whenever you see edge scotoma, you always concentrate what is the visual sensitivity, retinal sensitivity, measure retinal. Here they are all absolute scotomas. That means this point is not responding to the maximum light intensity. And here also absolute scotomas. When there is an edge points are showing absolute scotomas, and the next points are almost looking like good sensitivity points, 21, this thing. you always think and ask for repetition of the field. When we repeated the field, again, he's a well-done field, and almost they disappeared. And because of these things, actually, they are all rim artifacts. And in these things, you can ask the OCT also. OCT, if it also shows absolutely normal, then you can confidently say that there is no glaucoma. But most important thing is, he should be kept under observation. He is always glaucoma suspect. Glaucoma suspect can say at this time he is normal, but he may get the glaucoma in a later age. So you should always say that you are at risk, but at this time you are not having, and you should review the case after 1 year at least. You see, the analysis of the nerve fiber area defect, always you see, seeing the green and don't leave the printout. You analyze what is the neuronal, the axonal thickness. Here, the axonal thickness is 126, 153 is very high. He is not likely to get glaucoma at all. Suppose normally it should be around 100 microns, 110. He is having 117, 151. So he had a very good neuronal axonal strength. And he is not likely to get actually. You can tell, you can give confidence to the patient. He got very good axonal strength, and but you should be careful. This patient actually diagnosed again on disc disparity, pressures are around 20. Another take-home message: whenever you suspect glaucoma, and when there is a CD disparity of the both eyes, always interpret the visual fields, taking the right eye field with right hand and left eye field with left hand. That is very important. And you see in these things, the field defect, this is Anderson's criteria, it is fulfilling Anderson's criteria, well done field, PSD is less than 2%, glaucoma field test outside limits. And most important thing, if you notice, this is the nasal step here, and here is the nasal step in the left eye. This is actually the temporal scotoma. Here also, this is the nasal. This is the temporal scotoma. Again, this is the temporal scotoma. At the same place, the field defect is occurring. And later the patient, because when there is a same place occurring the field defect, something is the common factor is there. And so always evaluate the single field analysis printouts of both the eyes simultaneously. And that also gives you to strengthen your glaucoma suspect to be labeled as glaucoma. So this is the third case. This is also a disc disparity. The pressures on 20 around 20 with a strong family history. And all these patients, what I am showing, all these patients are under my care for more than 10 years. No, and actually this is the glaucoma suspect, but he's proved to be glaucoma patient, and this is the presentation. Whenever you interpret visual field, you always start with a probability plots. Always our aim is probability plot. Our aim is to know whether, because there is no clue, still he is a glaucoma suspect, and our aim is to fulfill whether the patient is having Anderson's criteria fulfilled or not. Can anybody now say, in this case, anybody can interpret this field? Only anybody? Okay, this is the field defect, and well done. Whenever glaucoma suspect, you always see how is the patient done with a well done field with a SETA standard. And the pupil diameter you have to write. Normal pupil diameter is usually around 3 millimeters. If it is the pupil diameter 5, you may get a little 1 or 2 dB total increase in the retinal sensitivity. That may be the effect of the pupil size on the field. If you want, you can consider pattern deviation plot in the when pupil is dilated too much. So in this case also, this patient is fulfilling Anderson's criteria. And the other eye is, even though same thing here also, it is appearing the scotoma here, and followed after 1 year, and still it is persisting the field defect. And the OCT is also showing the thinning of the RNFL here. Usually when the peripheral retina is involved, the OCT will show actually at 12 o'clock or at 6 o'clock. That is the direction. All the peripheral fibers, they will enter into here. So the thinning will be straight. If these arcade fibers will be between say 7 o'clock to 8 o'clock or 6 o'clock to 7 o'clock. That also you can see in the OCT. So this patient is, even though you see the solid discs, they are almost looking normal, and around 20 pressures, strong family history, and the patient is having glaucoma and follow up for 1 year. This patient is under my care for the last 7 years and presented actually with the upper arcade and lower arcade fibers. And our still in the when the first visit came, because in the discs are not having any suspicion to say that absolutely there is no violation of the ISNP rule, there is no definite notch, there is no definite RNFL defect. But because when there is not there, we say that is a glaucoma suspect, but he's having upper arcade, lower arcade field defect and fulfilling Anderson's criteria. And this is the total deviation probability plot, and this is the pattern deviation probability plot. Whenever there is a localized scotoma, both probability plots they look similar. But you can see here, some of the scotomas are in this superficial scotomas, they disappear in the pattern plot. So we can know the direction of progression. Here it is directing like this. So direction of progression also you must always concentrate. And the left eye is the same upper quadrant involved, and the patient is under treatment for glaucoma for the last 5 years. Here our aim is only diagnosing. Here also you see absolutely looking normal rim, not violating there is no definite RNFL defect, and the pressures are around 22, and even a single field analysis printout only early nasal step is there, and some here some scotomas are there, but fulfilling Anderson's criteria. And see, this is a very early, some scotomas are there, and sometimes these scotomas we say that it is normal. If there is no suspicion, we make these fields taken for normal. But I kept the patient on treatment for both the eyes because the pressures are around 22 and having scotomas where the scotomas will appear in the areas of glaucoma, scotomas where glaucoma will be producing, and followed up. 2017, this patient kept on treatment. This is the 2017. The right eye is absolutely almost normal, but the patient is kept on treatment. In 2019, early 90s, he had a disc hemorrhage. He had a disc hemorrhage in the right eye, and the right eye is now showing the scotomas. You see, and 2017, absolutely normal field. Once in 2019, he started developing the field defect. And 2021, same, it is maintained that this is the left eye and this is the right eye. And the patient is stable under treatment. And because this 10-2 is normal. And this is also, I saw this patient 2006. 2006, the pressures are around 20. At that time, the CC, central corneal thickness concept was not there. Actually, the put on bag, it is looking like actually a large physiological cup. And there is no, absolutely the rim, there is no notch or anything. No nerve defect is there. And both the eyes, but the fields are looking like this. The field here, upper, and this is the field. This is the reasonably well done field. And because the pressure is 22, I kept the patient on treatment because he's a school teacher. She is a school teacher. She got transferred and went elsewhere and diagnosed as a physiological cup. She stopped the treatment. And after 10 years, she came to me. with advanced fields. See, 2006, this is the fundus photograph, and 2016, the eye became pale. And you see, this is the 2006. And usually, there is nothing wrong if anyone diagnosing as a physiological cup. But the field is, because of the 22 pressure I started, and they stopped the treatment and the field became like this. At this stage, I did a trabeculectomy, I did cataract extraction, and I could retain the vision, whatever this teacher is having. Still, she is under my care. Now, up to now, the discs are looking normal. So most important thing is when the peripheral fibers are involved, usually we may not able to see any disc change. Here, once you see the difference between the previous printouts and this printout. Now this glaucoma started coming to the almost within 10 degrees. It is touching the 10 degrees. Once if it is touching the 10 degrees, you see the nerve fibrillary defect appeared. Here it is actually upper arcade and lower arcade. This upper arcade, because of this, the notch is there, nerve fibrillary defect is there, and this is due to upper arcade fibers. You see a small RNFL defect is there, reaching the edge, reaching the cup. See, this is another, again, this field, this scotoma is reaching within 10 degrees and RNFL defect appeared. And if you don't see RNFL defect, and it's almost, the notch is not very well appreciated. We may miss the notch. We may say that still ISNT rule it is following. Inferior is more than superior, but RNFL defect is there. And once the field defect extending into the 10-degree area, you will appear the nerve fibrillary defect. Here you see the nerve fibrillary defect, and the field defect is almost reaching the 10-degree. And once you see a nerve fibrillary defect and with a notch are violating ISNT rule, therefore, in the peripheral fibers, extreme periphery and coming into the mid zone in the type 1 glaucomas, then we will have a nerve fibrillary defect, and it is once it is an established case of glaucoma. So once it is an established case of glaucoma, what is our aim and what you should look for? When it is a glaucoma suspect, our aim is different. Our aim is only diagnosis. Then you concentrate on point pattern and how the patient did and what is the Anderson's criteria, where is the scotoma. With that we concentrate. Not actually if you diagnose it, and then okay, you start with one drug regime. And the most important in that is diagnosis. Here it is a diagnosed case. With definitely you don't require visual fields to diagnosis. And because from clinically we know the tensions are high or not high, that is a different aspect, but definitely from the fundus. Then what is our aim? Our aim is how best the visual fields help us to set the target IOP. Aim is to target IOP to arrest the progression and set up new fields. Then you always look for the probability plots. And probability plots, what you see, what is the location, what is the extent, what is the direction of progression. These three things will be known from the probability plots. Then you see the total deviation numerical plot to know the depth of the scotoma. And you see the raw data within 16 points. What is the retinal sensitivity, whether the patient requires 10-2 or not. And how often the test should be repeated. So whenever I ask you to interpret visual fields in a case of established case of glaucoma, all these things are required. So now I will be showing that this case. The left eye is showing a field of it there. Anybody is there to interpretation? Can anybody interpretation? Anyone take the come forward? So
Reddy, you can ask them by name.
The name.
Otherwise, they will not come forward.
Names I do not need. If they give some names, I will ask them. Who is the students? If they voluntarily, if they give names, I will ask their names and.
There are there no.
But
we have circulated the names no.
No, you don't. Even now, if you have, you can ask Ajit Babu. Ask them to ask. You can ask them. Anybody voluntarily comes out. If it is an established case of glaucoma, so in established case of glaucoma, you always interpretation starts with probability plot. Anybody is there? I will describe two printouts and later they can tell. So you always, in interpretation, you always start with the probability plots. While understanding, we came from patient data, test data, reliability data, raw data, grayscale. We come like this. But while interpretation, we take what is required. Now, this is the probability plot. You see, start with the probability plot. From the probability plot, I told you what is the extent, what is the location, what is the extent, what is the direction of progression. Here, it is the upper nasal quadrant, upper arcade scotoma. Both probabilities are looking similar. We can almost similar. This is occupying almost. It is. We are seeing a black squares only. We do not know the depth from the black square. You should always tell that I am seeing loss of retinal sensitive points with a p-value less than 0.5%, almost coming to the 3-point degree. That's all. That more than that. And when you come to the probability, the total deviation plot, you can tell that the loss of retinal sensitivity is almost 20, around 20, almost in the 4 points, and in the central point minus 12. And the mean deviation is, that is about the total deviation numerical plot, and it gives you the depth. The mean deviation is minus around 5 dB. You see, I told you in a localized scotoma, the mean deviation is always less than what it exactly. So here, even because this loss of retinal sensitivity is distributed to all the points and accepts as a mean. So in a localized scotoma, mean deviation is around 5, but if you see the total deviation numerical plot, it is around 30. So you concentrate on the 16 points, and there is an absolute scotoma here. When there is an absolute scotoma, you should always ask for 10-2. The indication for 10-2 within 16 points within 10 degrees circle in the RAS scale, you ask for 10-2. 10-2 is also just reach at 10-2 and see the scotoma. So this localized scotoma is almost progressing towards the fixation. So you must be very alert. When a scotoma is progressing toward the fixation, even though the mean deviation is 5, and your target pressure should be aimed at a lower level. This is another case. This is also established case. This is the right eye. This is the left eye. Both are showing nerve-fibrillary defect, and both are showing almost symmetrical field defects. And established. Once again, any case, you start with probability plot. I told you in the probability plot, you see the location, the extent, and direction of progression. See, this is the field defect. And here, if you see, the superficial scotomas, they disappeared. That means it is going like this. Even here also, the superficial scotoma is disappeared. It is progressing both away and toward the fixation. And if you see that the field defect, the loss is around 9, 10, 9, not as severe as the first case I showed. The mean deviation is -3. And there is no need for 10-2 because the 16 points within the 10 degrees are normal. And these are on these basis we set the target IOP. This is the left eye. Anybody can interpret this field. In this, whenever in established case, we don't give much importance to PSD because I never talked about PSD. I never talked about GST. I never talked about how the patient did the test. I didn't give much importance to the strategy because it is established case, and in this established case, we always concentrate reasonably. If the reasonably done field and 24-2 or 30-2, it doesn't matter for much. And the SETA standard or SETA fast, it doesn't matter much. And you concentrate on the probability plot, the location, extent, direction of progression, depth, and the central 16 points of the 24-2, whether an indication for field effect or indication for 10-2. Another most important thing is, even in a relative scotoma, if in a relative scotoma, there is no absolute you see a 0 in total deviation numerical plot is normal point. There is no deviation. Absolutely, the measured retinal sensitivity and the patient data, raw data are same. That is why 0 in total deviation numerical plot is a normal point, whereas 0 in absolute scotoma is in a raw data is absolute scotoma. So another most important, if you notice, this is a field effect and this is a relative scotoma. A relative scotoma also can produce RNF field effect. That is most important take home message. The RNF field effect doesn't mean that there is almost loss of retina and absolute scotoma. It is not like that. Relative scotoma is producing and patient on a single drug therapy. And this is another case actually started periphery and almost reaching up to the fixation. And previously, this is the conventional concept. If you see, now anybody can interpret this field. Established case of glaucoma, almost upper arcade scotoma is involved. The probability plot is showing the lower arcade also. Anybody? So again, you see the upper biarcade scotoma and upper arcade scotoma almost showing absolute scotomas. And what the probability plot is, pattern deviation probability plot is telling. Because when it is being during conversion, the superficial scotomas, they disappeared. That means the lower quadrant also recently it said it is progressing. That means if the patient is already on treatment, it indicates that the treatment is not enough. It itself is telling that it is progressing. They are all recent onset of scotomas and they disappeared. So this is the direction of progression. This is the extent and the location you see from the probability plots, and the depth of the scotoma from the total deviation numerical plot is the mean deviation is -15. Here, even though they see -32, -32 around 20 and all the quadrants, when expressed as a mean, it became 15. In a localized scotoma, the mean deviation is always, this is a very important, while in a progression, in a localized scotoma, 15 is changed to 17. That means the difference is only 2 dB. When you come to the here, it may be 8 dB loss. Difference will be there. So the concept of mean deviation in a localized scotoma is very important. Even though it is less, it is huge. And you concentrate on the 10-2. There are most of the absolute scotomas. There are 3-degree points. There are 9-degree points. And they are showing absolute scotoma. There is a definite indication for 10-2. And you repeat the test with 10-2. Once in 10-2, you concentrate on the raw data. So these absolute scotomas are almost coming into this is the 1-degree point, and these are 3-degree points, almost reaching the fixation. And in another take-home message from this case, in a follow-up test, you need not go for 10-2. You can go for macular program. Macular program is nothing but the 16 points of 10-2 within the 3 degrees. Within the 3 degrees, there are the 16 points will be there in the macular program. Actually, in macular program, you can go for macular program with size 3. You need not go for size 5. Size 5 means advanced and almost not able to do the routine field. You go for size 5, or routinely you can go for macular program in the follow-up test, because you know that already all these points are gone and you need not test again. You test this area. If they're reaching, that means the macular program will give you the progression in this area or not. So you can do the macular program very frequently because hardly it takes 2 to 3 minutes. That is why, but in the macular program, they have not given single field analysis printout. And they gave 1 in 3 printout, and that is why I asked them in macular program if the patient is doing this, because we have normative data. When there is a normative data for these points, you can have a single field analysis printout, and we'll be utilizing more frequently. They may come out with the single field printout for this macular program also. This is the left eye. Again, you go, I told you, you stick to the fundamentals. You start the interpretation from the probability plot, and you start interpreting the total deviation is showing biarcade, And here the lower fibers, lower scotomas, they disappeared. That means it is progressing. This is the superficial scotomas. You see, they are all minus 14, minus 5, minus 27, minus 4. Here
My video stopped.
and you concentrate again on the 10-2. Here, absolute scotomas are there, and you go for 10-2. But if you see, this 10-2 is more advanced than the other eye. Even though the 24-2 is showing not as serious as the right eye, and this is the right eye 10-2. This is the left eye 24-2. This is the left eye 10-2. Here the and again you see the advanced. And in this follow-up test, you can go for macular program. I mean, instead of going for 10-2. So this is a advanced case of where glaucoma started in the periphery and coming into the center. Now we will go for glaucomas where they start from within 10 degrees. Within 10 degrees. And you see, in all the cases, you see the nerve fibular defect. This is the nerve fibular defect.
Can you start the video?
This is the nerve fibular defect. In this thing, if you observe, it is going towards the macula. It is going towards the macula. And now we'll start. When you suspect a nerve fibular defect going towards the macula, and you suspect the glaucoma within 10 degrees. But normally, whatever it may be, always take the once you suspect glaucoma, you always ask for 24-2. And you look for deep scotoma and whether you see any indication for 10-2, and then repeat the 10-2. Usually NTGs will have glaucomas within 10 degrees, and because the diagnosing the NTG is very important because beta blockers are contraindicated. Someone has to mute them, no? This patient, can anybody can interpret this field? This is the 24-2 single field analysis printout of the right eye with CETA standard and the reasonably well done field fixation losses, false negatives will be reasonably good because this is established case. We can accept these things, and here we don't bother about PSD and glaucoma imaging test. Disturbance is coming. And now, can anybody can interpret these? Just you read, you interpret starting from the probability plots. This is the localized scotoma. The probability, the showing scotoma almost horizontal on both the sides, both on the temporal and nasal. This. And if you see the total deviation numerical plot, almost there is an absolute scotoma here and 18. So glaucoma, always look for the deep scotoma, which tells you from where the glaucoma started. Here you see that 3 degree point is showing absolute scotoma, and here also an absolute scotoma in the raw data. And when you see an absolute scotoma, you see the mean deviation is only -5, and VFI is 84. And when we repeated the field with the 10-2, so this patient have been following for the last since 2017. This is the 2018 field. You see, they compare the 10-2 with a mean deviation of -5. When it took the 10-2, it is showing -12, and PSD doesn't have any value once it is diagnosed. And VFI you see 84. VFI is not given in 10-2. Actually, VFI once in the glaucoma starting within 10 degrees, there is no value for VFI. Once you don't never interpret this field and never comment, never give any diagnosis. Once you see an indication for 10-2, even the indication for 10-2, you go for 10-2. Afterwards only you should comment, and afterwards only you aim for target IOP. This is actually because the other eye is having advanced glaucoma. This one square in the 3-degree point and reasonable. If other eye is also normal, sometimes we ignore this point. So whenever you see a black square in the 3-degree point, and you see here also it is C. In a gray scale, if you see a black area, that means the loss is huge. See, -19. Because already the retinal sensitivity is around 40, and this retinal sensitivity around 30, and more than 10 dB is there to produce actually a scotoma here. Otherwise, it looks as if the normal. So losing the brightness in the central 10 degrees, that is a huge important to suspect something is going wrong in this. Scotoma need not appear. Even losing the brightness is itself, it gives a clue that something is going wrong within 10 degrees. And if you ask for 10-2, then and you can pick up.
Reddy, if you are seeing it is only one value is -19. Rest all -1 or -2.
-1. Actually, this I started here, I tell you.
Is it possible to have such a localized deep defect?
No, I tell you. Actually, what is happened, this is the 3-degree point. And the distance between this point and this point is 6 degrees. If you see, this scotoma started within these points of 24-2 and going in between the points. And now you ask for 10-2. See that 10-2, now you can tell that the loss will be there in these points. Here the retinal sensitivity is 18, 20. Here the loss is there, 32. Because it is going here. Let's see, 13, 0, 0. So this localized scotoma passing in between the points of 24-2. This concept, because of this only, we asked actually to add some of the points in between. And that is how the 24-2C Theta faster came into existence. Because we are likely to miss these glaucomas. But actually by adding those 10 points, it did not serve our purpose. So again, we have to go for even from 24-2, you always look for 10-2, whether there is an indication or not. And if you see in this case, even the OCT optic nerve head also did not pick up at this stage. But if you take ganglion cell analysis, it picked up. For the eyes. So ganglion cell analysis is a very, very important tool to pick up the glaucoma starting within 10 degrees. It is a very important tool. So even OCT, optic nerve head may not able to pick up, but whatever it may be, you ask for 24-2, strictly follow fundamentals and see for look for 10-2. And another most important thing is the retinal nerve fiber defect going towards the macula. I will be telling about the indications of 10-2. It is a big chapter. I will be telling again. So in this case, you see anybody now, this is also, you are seeing optic nerve fiber defect here and you are the nerve fiber defect here. Actually, it is going towards the periphery, it is going towards the macula. And if you take the 24-2 and both the eyes, the left eye is looking almost normal, except some few scotomas here. But a nerve fiber layer defect is there.
Here, the nerve fiber layer defect is there, but if you see the field, it is not appearing.
No, here that is the most important I am telling. The retina starting from the periphery, if you take 30-2, you may get some scotomas. Or if you go still more periphery and you do custom test, and you will they will appear. Only you always say the tested area is normal. You are not testing the entire retina where it exactly started. So definitely there is a field defect, and if you go for the periphery and make the custom points, and if you take those custom points where you are supposed to see, they will be abnormal. But because we cannot test every point of the retina, it only gives us to, it gives a clue. Here it gives a clue, and this eye is giving the clue, and here it is getting a clue. Okay. And now we start with the probability plots. Again, whatever it may be, a probability plot, where exactly located, extent and direction of progression. And you see the deep scotoma. Here it is the deep scotoma, minus 33, minus 35, minus 4, minus 33. This is absolute scotoma. This is absolute scotoma. This is absolute scotoma. This is absolute scotoma. Therefore, you see the VFI is 83%. Mean deviation is only 7. So never give value to the mean deviation unless otherwise you see these values. Mean deviation only tells about the average loss. Even this localized loss is distributed among all the points and expression. So the grading glaucoma on the basis of mean deviation, purely on the mean deviation, is a wrong concept. The most important thing is the mean deviation along the again retinal sensitivity within 10 degrees. That should be added in the staging of glaucoma. And coming to the 10-2, see, this is the 10-2 almost coming to the near. In these situations also, you can go for a macular program with size 3. And we have to repeat the test quite frequently, once in 4 months. It hardly takes 2-3 minutes for the test. If you want to take 10-2, we have to test 68 points. Whereas in macular program, only 12 points, almost 1/5 of the points. If you test, we will be knowing what the required information we will get. And if you see this left eye, you see the left eye, I told you, the retinal RNFL is showing thinning. It is going to the periphery. Whenever you suspect extreme periphery, the nerve fibular thinning will be straight, either at 12 o'clock or at 6 o'clock. So here it is showing the field effect. Somewhere here it is showing the indication is there. See, it is actually 100. I always say, you always look for the micron thickness. It is 115 and here it is 66. There is a huge loss in the periphery. And in this case, actually, again, this is the cataract. With the cataract, I took the field and I could see the nerve fibular defect here. And the field was taken. The total deviation probability plot is showing generalized depression with a few scotomas here. Then I told the patient, he's undiagnosed. He came to the first time, came for cataract and diagnosed glaucoma. We have to remove the cataract. Then I told the prognosis, you are having glaucoma and we'll repeat, we will have, and the cataract can be done, but visual acuity afterwards, you don't get 6/6, may not be getting, the field of vision may not be good. And the cataract was done. You can see, well appreciated. And the field was taken after the cataract. You see, there is no generalized depression. You removed because of the cataract, and once it becomes a localized scotoma and occupied. Now we will interpret this scotoma. So again, anybody can now, this is the actually glaucoma, anybody can interpret. I told you it is very simple. You start from probability plots. Your total deviation probability plot is showing again the scotoma crossing almost both temporal and nasal. Here the defect is there. Here they don't cross. Actually, it starts from here. Two separate scotomas. Here it is a separate scotoma. It is a different scotoma. The probability plot it appears as if it is coming like this. It never crosses. This is a separate scotoma. This is a separate scotoma. And see, only 3 scotomas are there with the black square. And if you see, it is minus 16, minus 10, minus 29, 10, 16, 29, 30. The retinal sensitivity, there is no absolute scotoma in this case. And still, this tells you there need not be absolute scotoma to ask for 10-2. This is the most important take-home message. There need not be absolute scotoma. To produce RNFL defect, there need not be absolute scotoma. And whenever you suspect, whenever you see a black square and a black square in the grayscale, you always ask for 10-2. When 10-2 is asked, you see this is the scotoma. And if you see, again, if you see, actually it is starting from a 3-degree point. And here also minus, here 16, minus 35, minus 26, minus 17, minus 21. So within 3 degrees, they actually started here. And it is going 8 and is going almost 7 here. And that means the glaucoma started at the 3-degree point and even involving the 1-degree point. So you must be very, very alert. Almost it is causing actually this patient later after this operated in 2018. In 2019, I did trabeclectomy in this patient. I don't want to take any risk, and I did deep sclerectomy with trabeclectomy to save the vision. Otherwise, you will become almost absolute scotoma and a black squares all will be there. In 10-2, another most important thing is you don't see a black square in 10-2 because p-value less than 0.5% is not calculated. You only see only this square only, p-value 1%, less than 1%. You don't see a black square in 10-2. You don't see glaucoma hemifield test in 10-2. You don't have a blind spot in 10-2. You cannot identify the which side it belongs unless otherwise you see which side which is written here. These are the differences between the 10-2 and 24-2. Now coming to now you saw glaucomas appearing within 10 degrees, and now we will see glaucomas appearing simultaneously within 10 degrees and outside 10 degrees. See, this is the nerve fibular defect, and here huge defect is there here, and another. It actually here it is going one, and it is one is going straight. If you see here, it is the nerve fibular defect here, and these are the printouts. Now coming to the first case. In this thing, now, if you see the total deviation probability plot, the scotoma is appearing as if it is a single scotoma. But if you see the grayscale, this scotoma is different and this scotoma is different. So grayscale will give us multicentric origin of glaucomas more than the probability plots. In probability plots, it appears as if you take, for example, this one. It appears as if a single scotoma biarcade. But if you see the pattern deviation probability plot, it appears is this scotoma central origin and peripheral origin. Well appreciated here, central origin, peripheral origin. Here, even the probability plot in this case is not able to give, unless this, but grayscale is giving the multicentric origin. That is why I told you, grayscale gives you huge information. The enlargement of the blind spot is better appreciated. Multicentric origin of glaucomas are better appreciated. And depth of the scotoma is better appreciated. Even if you have black square and if it is very dark, that means the depth is very high. And here also, the multicentric origin, not probability plot, it is giving. Now coming into the interpretation. So multicentric, what you see, look for the grayscale will give you some origin, but to interpret from probability plots, how they are looking. And again, you see the total deviation numerical plot. Here it is that we look for deep scotoma, absolute scotoma here. It is the deep scotoma here. That means there is a definite indication for 10-2. Unless otherwise you go for 10-2, never comment, never start the treatment or never comment the visual fields. You see this scotoma, huge scotoma. Here because the points are traveling between 9 and 10, they say 3 degree and 9 degree, they will be not measured in 24-2. Even the grayscale misses. And so most important, we cannot test all the points. We have to get the information from the single 24-2 and you ask for 10-2 if it is indicated. You always concentrate on the 16-degree points. Even there is need not be absolute scotoma. That is another important thing. Even if you see an absolute scotoma, you go for 10-2. Sometimes 10-2 may become normal. It doesn't mean that absolute. Sometimes It may be normal, but we will be knowing how exactly the status of the glaucoma. This is the right eye of the same patient. You see this one. And biarcade scotoma looking like, and actually this deep scotoma is embedded in this scotoma, but you see the grayscale is showing. And you can tell that in upper arcade scotoma, it is a by multicentric origin of glaucoma is showing. Here a deep scotoma, absolutely normal area, and another scotoma. Here the deep scotoma 0, and this 1721. Here you see the mean deviation is only -5. Visual field index is 86. Actually, visual field index doesn't have any value because it is taken from 24-2. It should have been, because at that time when the VFI they have calculated, they don't have the concept of glaucoma starting within 10 degrees. And the original concept is glaucoma starts at the periphery and comes to the center, and the visual field with some retention of field in the center. That is the original concept. But in 2000, from 2010 onwards, I have seen these patients. I have been telling in my instruction course in AOS and all, this classification of within 10 degrees, outside 10 degrees, simultaneously within and outside 10 degrees. You see, this is the scotoma, and with a appeared here, and you see the 3-degree point is showing absolute scotoma. This is absolute scotoma, but that means the scotoma actually started here, and another thing is at the periphery. You see, this is the glaucoma nerve fibrillary defect here, and another nerve fibrillary defect here, and merging into this. And in these patients who came macular program for the repetition and 24-2 also. In these patients, we have to go for 10-2 and 24-2 also. Sometimes the glaucomas, the peripheral glaucomas will be progressing, and sometimes in some of the cases, central area scotoma will be progressing. So in a progression, you have to go for 24-2 and 10-2 to assess the progression. In the glaucoma starting within 10 degrees, anyhow, we take always 24-2 and go for 10-2. And depending upon the status, we repeat the progression, which has to be repeated. This patient actually, this is, I saw in this patient actually 2011 onwards, this patient is under my care. And almost if you, this is the scotoma and this is this nerve fibrillary defect with a notch. And RNF, this ganglion cell analysis are showing. I always say that in the, it is going, if it is going towards the macula, it is from 7 o'clock to 9 o'clock. From 7 o'clock to, from 5 o'clock to 4 o'clock. These areas, if it is from the periphery, it will be like this from 12 o'clock. And if it is going towards the macula, this area will be involved. If this area, the upper also here, the upper thing is also there. This patient actually came to me in 2011. This is the 2011. At that time, I don't have the concept of this classification. And this is the field I had. I took it very light. I did not do in 10-2 in this case in 2011. And I started the treatment. I missed the absolute scotoma here and 3-degree point. And again, the patient came in 2012. In 2012, I took the field. You see the field mean deviation of -5 in 2011. The patient came and told that, Daksaba, I'm not very happy while reading and all. Then when I observed this photograph and going towards the macula and seen absolute scotoma here, then I took the 10-2. You see the 10-2, almost this scotoma is appearing at the 1-degree point. 1-degree point, actually it appeared. And this is scotoma. So the original concept of this, another thing I tell you, this patient, 2006, I've been following till date. 2006 and 2016, 2018. Almost single pin analysis printout is almost looking stable, -5, 2016, -5 around, but 2018 it came to -7. In 2016, actually, the patient told me, he's an intelligent patient, he told me that I am not very happy with with reading and all somewhat. I look for cataract, there is no cataract. You see the visual field, the foveal sensitivity is also reasonably good. When I saw this field, even 2005, there is an absolute scotoma here. And I missed this in 2005. I missed this absolute scotoma. And this absolute scotoma is persisting. 2016, then I asked her for visual field 10-2. See, in 10-2, what is exactly happening? This is actually going in between the points. This is 2018 field. 2016, this field is not as dark as 2018, but it is going in between the points. That means because in this, even this field, they started simultaneously within 10 degrees and outside 10 degrees. Unless otherwise you see in absolute scotoma, if you see, had I asked her for, then I should have picked up this. And you see the ganglion cell analysis. This is the left eye. The ganglion cell analysis is showing the defect. RNFL is giving out this thing. Again, see, this scotoma is going in between the points between 3 and 6 degrees, going like this. And this is the peripheral, and this is actually biarcade scotoma of 10 degrees and the biarcade scotoma of 24 degrees. So with this background, whenever you want to interpret visual fields, you always go for probability plot, and you see what is the extent, what is the location, what is the extent and direction of progression. Then immediately you go for total deviation numerical plot. You see what is the loss and the raw data, what is the existing retinal sensitivity. Is there any absolute scotomas or gross loss within 16 degrees, within the 16 points of the 10 degrees of 24-2. And if the macula, if the retina, the RNFL is going towards the macula, and there is always an indication for 10-2, we repeat the 10-2 and see what is the 10-2 field. Then you want to set the fields. In most of the cases, I actually within 10 degrees, we have to keep the IOPs at a very low level. And any beta blockers also, if they're involved, normal tension glaucomas are more common in within 10 degrees. And both are involving, usually pressures may be on higher side, both 10-2 and 24-2. And usually outside the 10-2, mostly they are POEGs of raised IOP. So the raised IOP, usually peripheral type 1 and NTGs type 2. And type 3, both we can have raised IOP associated or NTGs depending upon the presentation. So with this concept, this is the analysis indication for 10-2 I made. I will show you this case, what I saw in 2011. See, 2011, this is the single field analysis printout, and this is the 2014. This is also 2014. I took the 2014 and see 10-2, the scotoma appeared. Still, the 24-2 is grayscale is normal. So never depend on a grayscale for the indication for 10-2. You see absolute here a deep scotoma is there. So I told you in the central area, early loss of retinal sensitivity will be missed in the central area. The only thing is the loss of brightness is there. Loss of brightness is there when compared to this area, but the loss of brightness our eye will not pick up unless you know that the disappearance of the brightness is a positive point. And it appears because we compare this area and this area is around 28 retinal sensitivity. Here even 30 also will be better than this area. But if it is 30, already 8 dB is lost. So anybody loss of retinal sensitivity more than 8 dB will have a black square. The black square we will have a p-value less than 0.5%. Loss of retinal sensitivity more than 8 dB will be represented by the black square. The black square can never be ignored. Here, see, even the normal, you repeat the test. This is the area. Even in 2017, Still the grayscale is normal. But the probability plot you show, you see the probability plot is showing, and this is the 17. This scotoma, still it is appearing, passing through the between the points. And in 2018, this scotoma appeared. This scotoma, 2018. So much time it has taken for a scotoma to appear in a grayscale. So never depend the grayscale to pick up an indication for 10-2. You concentrate on the probability plot, and you concentrate a deep scotoma, a black square, and ask for 10-2. The same thing I told you. So this is the raw data, and this is the total deviation you have to plot. Nobody on the earth will ask for 10-2 when the raw data is like this, unless otherwise you had an experience. Only experience will teach us. See, even in 14, 16, we see still GDP 0 means normal, 33 is normal. In this thing, raw data showing the absolute scotoma. And 10-2 is taken. See, in 24-2, in this case, it is stable. Mean deviation -3, -3, -3. But in 10-2, it gone up to from -1.74 to 6.47. So in progression, you have to concentrate on sometimes this some of the cases I got where they show progression in 24-2, even though they started within 10 degrees, they are stable. The most important thing is whenever there is we have to keep the patient in this thing. I waited for 5 years. It is actually deepening. I did trabeculectomy. After 2017, it became stable. We have to keep the pressures very low. The medical management, because with an experience, I found we are not able to stop this scotoma growing, progressing. And in advanced case, you see, this is the 10-degree field. Whenever there is a 10-degree field is much involved, you can ask for macular program with the size 3. They're well done field. This is the size 3. And because it hardly takes, it's a 16 points, it is giving the information. Almost this is the area we want to concentrate. Okay, this area is being saved. Because instead of testing all the 68 points, you can test this for 16 points and you can get the information regarding the. Here it is our area of concentration, and this information we can get from macular program. So anybody, I want actually someone to interpret this field. So I told you so much. At least I want someone to interpret this field.
Dr. Amit?
Yes, sir. Good evening. Sir, by looking at the probability.
No, you start from fundamentals. This is the single page analysis printout.
Yes, sir. Of 24 of the weight I with there is very less fixation losses. False positives is also false positive 7%. So it is reliable. The fields are reliable, sir. So we can. Yes, sir.
What is the foveal sensitivity?
The foveal sensitivity.
32 dB.
The foveal sensitivity. Where is it?
32 dB. No? Here I wrote.
Okay.
And what it indicates, if the foveal sensitivity is good, what it indicates, the refractive error correction that is given is correct.
Good, that is fine. So that's correct. So
then you start the okay, it is a reliable field of the right eye, done with Sita-fast.
Sita-fast is
with the foveal sensitivity of 32.
Yes, sir.
Then you want to interpret. Now you start interpreting.
Okay, sir.
You start interpreting the probability plots. What probability plots are telling you?
Sir, from the probability plots, we can see that there is a arcuate scotoma, sir, in the superior field, which is
superior. Which area? Superior nasal. upper arcade. Superior
Yes,
lateral upper arcade scotoma almost crossing the horizontal meridian.
Horizontal meridian, sir.
All are represented by black squares.
Yes, sir. Represented by black squares, and it is.
Can you tell me what is the depth of the black square? Can you imagine?
Sir,
Any black square more than -8 is a black square. Can you tell? Can you tell without seeing the total deviation numerical plot or raw data? Can you tell approximately what would be the loss of what is the depth? Can you tell? Without seeing total deviation plot and raw data, can you tell?
the loss of what?
No, this black square. What could be the loss or what could be the retinal sensitivity at this point? Can you tell without seeing raw data and the total deviation numerical plot?
Yes, sir. It is p-value less than 0.57.
That's all. P-value, it doesn't tell you the depth. Can you tell without seeing approximately? Can you tell?
So there is a big, so because it is at the center, at the fixation point, sir, so there is a huge loss of fixation. Loss of
No,
fixation.
no, I didn't follow. What I'm telling?
Sir, since it is involving the central fixation point, sir.
No, central fixation point, a black square doesn't mean that it can be deep scotoma. We saw a number of cases where a black square can be -9.
Okay, sir.
See the grayscale, it is very dark.
Okay, sir. Yes,
So
sir, it is going.
the grayscale can give you approximately, it is a deep scotoma, when a very dark.
Yes,
Next, you describe the probability plots almost looking similar. Both probability plots are in a localized scotoma. Both probability plots look similar. Why?
Sir, because
Scotoma, both probability plots they look similar. Why?
sir, because
they are looking both similar means the pattern deviation and total deviation numerical plots are identical.
Identical, yes. Sir.
When they will be identical? During dispersion, we don't add anything. Best seventh deviation point will be almost minimal because most of the points are normal. So the best deviation point is minimal. So nothing will be added. Therefore, there is no change in both the total deviation, pattern deviation plots, and hence there is no change in the probability plots. They look similar. Okay. Now coming into the total deviation numerical plot. See -34, -34, -33, and absolute scotomas here. That means the glaucoma started at the center.
Center and periphery, it is going towards the periphery. And sir, at the raw data, we can see there are some losses central less than 0 are there in the center. So we should do a.
No. What do you understand by 0 and what do you understand by an inferior sign in front of 0? What do you understand by these two?
Sir, 0 in raw data means it is an absolute scotoma.
Then what is this one? An inferior sign in front of 0.
Sir, that no, sorry, I'm mistaken, sir. 0 in front of in raw data, 0 means it is. We are not comparing it. So, sir, that means it is 0 is not good.
No. 0 in raw data without an inferior sign in front of it. That means it is responding to the 10,000 ASB units.
Okay.
If it is not responding even to 10,000 ASB units, an inferior sign appears in front of 0. But practically both are absolute scotomas.
Okay, sir.
Next, there is an indication for 10-2.
Yes, sir.
So you go for 10-2.
Yes, sir.
Here you see the foveal visual field index is 80% almost, and the mean deviation is -8.
Yes, sir.
And now you come to the 10-2. 10-2, right eye with a foveal sensitivity around 35.
35.
And well done field. Fixation loss is 2/13. Okay, in this case we don't give much importance. But if you done the field well, then you straight away see the raw data. See, almost the absolute scotomas are almost reaching the 3-degree point. Almost this area is lost. and almost coming towards the, actually it is 30. So
Yes.
one thing is lucky, it is not coming towards the fixation here. It is going away like this. But you must be careful. It is 30, but it is becoming 6. So, but 27, 30, and 3 degree, 1 degree points are normal. Here, good. That is why the foveal sensitivity is so much. Very good. See, the foveal sensitivity is 35 because these points are normal. So our aim is to keep this area, and that is why in the follow-up test you go for backlog program and you see this area will be saved. So we have to aim for, if actually glaucoma started within 10 degrees and then going into the spillover in 24-2 what we saw. Can you interpret this field? This is the left eye of the field. There is someone come ask someone.
Dr. Reddy, let someone else do the interpretation.
Someone.
Dr. Anita.
Yes, sir. Good evening, sir.
You can go.
This is a single field analysis of left eye 24-2, which is showing superior
24-2 Seta fast. You have to test 24-2 Seta fast.
Yes, sir. 24-2 Seta fast, which is showing superior.
How you did the test with the radar ball? Which how are the fixation losses?
Sorry, sir. Yes, sir.
You tell.
Sir, with fixation losses being 2/30.
What do you understand by 2/13?
Fields are reliable.
No. What do you understand by, what do you understand by 2/13? 13 times the light fell on the blind spot. 2 times he responded.
Yes,
that is the understanding of 2/13. False positives 2%. False. What do you understand by false positive?
So false positive means that the patient, we did not show the
patient
light,
responded when there is no stimulus.
Without, yes, sir.
The patient responded when there is no stimulus. What do you understand by false negatives?
So false negative means that the patient did not respond to the stimulus given.
No. The patient did not respond to a brighter stimulus to which he has to respond. Yes, sir. That is minus. Okay, good. Then foveal sensitivity and now
the foveal sensitivity is 28 decibels, which is slightly decreased.
Okay. Then you
yes, sir. Now, yes, sir. Coming to the probability.
Interpretation of the field starts with probability plots. Okay, start with the probability plot. What probability plot is showing?
Sir, in the probability plot, we can see that there is superior arcuate scotoma. This is of the right eye. So, sir, this is temporal field showing the scotoma.
No.
Involving the temporal field, sir.
No, this is the upper nasal, no? Blind spot is in the temporal.
Sorry, sir, this is the left eye. Sorry, sir. Yes, sir. This is the left eye, so this will be the nasal part. Yes, sir.
The upper nasal scotoma is there. Here, upper nasal scotoma, upper arcade. Some scotomas also started here. They decide superficial scotomas. What is the most important information you want to get from grayscale in this case? What is the grayscale is telling you in this case? What from the probability?
Macular area, did you comment, Anita?
Macular
area.
No, sir, I did not come. Sir.
You see, there is a deep scotoma here. There is a gap.
Yes, sir.
So,
yes, sir.
It is actually multicentric origin of glaucoma. From the probability plots, it is looking like as if a single scotoma. But if you see the grayscale and you see the absolute scotoma here.
Yes, sir.
That means glaucoma started here, glaucoma started here. In this
yes, sir.
Sir, okay. Then coming to the totally, this is the total deviation numerical plot. This is the pattern deviation numerical plot. What?
Yes,
this
sir.
is, yeah, this is the raw data. Now interpret what we are going to see when we are seeing a black square here. Now we see for indication for 10-2. Is there an indication for 10-2 in this case?
Yes, sir. So there is a single point at the center which shows a sensitivity of my less than 0.
Even 0 may not be there.
And
If there is
also,
a class
sir,
reduction is there. Suppose if 0 may not be there, even 11, 17,
yes, sir.
16, even those are indications for 10-2. 0 is, if there is 0, you will always go for it. Even if there is no 0, you should always, when there is a gross reduction within the 16 points of the 10-degree circle area of the 24-2. See, this is the 10-2.
Yes, sir.
You read the 10-2. Same
Yes,
thing.
sir. Sir, this is a visual.
Hmm.
Sir, the fixation losses being
This
0.
is the 10-2 single field analysis printout of left eye
Yes, sir.
with
Yes, sir. This is a
strategy
single.
theta past.
Yes, sir. Sir, the fixation losses being 0/13, false positive 4% and false negative 8%, which indicates that the field is reliable. The foveal sensitivity here is 31 decibels. Then coming to the pattern deviation plot, sir, we can see that there are.
Why you go to the pattern deviation plot first? Pattern deviation plot, why you in this case?
Sorry, sir.
Why you want to go to pattern deviation? When there is a localized scotoma, you don't require a pattern plot to get the real information. The real information, raw data, total deviation numerical plot, total deviation probability plot. When there is a generalized depression, this is now generalized depression is removed and we see any localized scotoma and what is the information of the localized scotoma. Then only pattern plots. Okay. Total deviation probability plot. This is the which
Sir, in the total deviation.
What is this one? Is it nasal or temporal?
So this is the nasal part of the
Why
field.
it is nasal?
So it's a left eye. So this is the left eye.
No, this is the left eye.
This is the left eye because supposed to be the left eye blind spot here. Temporal side, so nasal. Unless otherwise you see this which side, you cannot tell that. Okay.
Yes, sir. Yes, sir.
Actually,
so then
involving almost now you go for involving the here you see 6 degrees in the within 1 degree point. See, 27, 27, 30. That is why the foveal sensitivity is how much this one?
31, sir.
31. Because all these fibers are normal. This thing, that is why 31.
Yes, sir.
So, actually, the bicentric, multicentric glaucoma, both involving both center and the periphery. And regarding progression occurs, most progression, I will tell you some of the points. The single field analysis printout is given in a different format. This is the overview format. Overview format will have everything information. Date, strategy, GHT, false positives, false negatives, fixation losses, PHT, mean deviation index, foveal sensitivity. But this TDNP and PDNP will not be there. These two will not be there. Instead of that, raw data is given. They may ask the question, two things which are absent in the overview printout from the single field analysis printout. Total deviation numerical plot and pattern deviation numerical plot will not be there in the overview printout. You see, I will tell you this one. This is actually, I told you, what do you understand by inferior sign in front of 1? I told you in the last session. If you see normally inferior sign appears in front of 0, that means absolute scotoma, that is not responding to the brightest light. If you say inferior sign in front of 1, what it indicates? That means the light is becoming dim. It is not the brightest light. When it is not the brightest light of that perimeter, the inferior sign appears 1. And then if it is still more delayed, if it bulb is not changed, it will become minus. It is in front, 2 in front of inferior sign. Okay. So in raw data, always you should look for raw data, whether it is how is the bulb, whether it is, if there is no absolute scotoma, you cannot comment on the bulb. Here you take the field 2015 and 2016, false negatives are 16% and mean deviation is minus 25. I told you in the last session, the false negatives are 27 and here minus 16. Whenever false negatives are high, the mean deviation will be more than this one, no? False 16% will have a mean deviation 25. 27 should be more than 25. Last one should be. No? Have you caught my point? See, why it happened? Because in the first test, the unreliable field. When the bulb is replaced, you see, the inferior sign appeared in front of 0. That means the bulb is corrected. And this is the real field. You should get a doubt. False negatives are 16%, mean deviation is minus 25, and false 20% should be more than this. If you don't see the raw data, you think that something is there. If you see the raw data, you see inferior sign appears, the bulb is dim and it should be replaced. So take for example this field taken and you say that it is stable. Minus 29, minus 29, minus 29. Is it stable? You say any comment on this? When in advanced glaucoma, you are supposed to take the 10-2 for protection analysis. You see, all are absolute scotomas. Very few points are there in the center. If there is a loss in among 3 points, the loss among the 3 points will be distributed to all the points and expressed as a mean. And you don't appreciate any change in the mean deviation. And you think that it is stable. So selection of the point pattern is very important. In advanced glaucomas, if you take 24-2 and you say stable, it appears to be stable. But if you take this patient, actually, I saw this patient in 2003. See, in 2003 also, the glaucomas are there within 10 degrees. And and he got transferred to somewhere and maybe off treatment and all. Again, he came back to me in 2016, 2003 patient coming with 2016. See, I got the data of the patient. And I saw he got the branch vein occlusion, sir. Ajit Babgar, he came with a branch vein. And when I took the fields, see, luckily, it didn't progress towards the center, away from the center. And this is the patient I told you. No. This patient actually, the sister of the same patient which appeared within 10 degrees, just like biarcade. She is the sister of that patient. And I saw this patient in 2005 and early diagnosed with glaucoma. I wrote no change in the plot. The 7th best deviation point is 0. And localized -1 here I wrote 7th best deviation point. And we started the treatment, but I saw this patient again in 2016 with advanced of the right eye. Actually, the patient, I asked the patient to keep the both eyes. Someone told, you put only the drops in one eye, and she started putting in this eye and not putting in this eye. This eye became advanced. So, whenever the patient comes to you, ask them always a glaucoma patient to come with drops and always check whether he is putting the drops properly or not. Here, unfortunately, the patient was asked to put in one eye and she started putting only this eye, which is appearing almost normal in 2005. And this eye became advanced. So, the progression of glaucoma always will be there. Only you have to check whether he is putting properly or not. And sometimes even the drops may be changed to lubricants sometimes. And so always ask the patient to come with the drops and check properly whether using the diagnosing glaucoma at early stage is useless in this case. What benefit we made to the patient? So diagnosing glaucoma at an early stage, ask the patient to come with the drops. And another most important thing is in all open angle glaucomas, ask the patient whether he is taking water in the morning or not. Well, because when we water drinking test, even by taking 1 liter water on empty stomach, the IOP will rise. I got number of cases when I diagnosed and we put on treatment. Whenever the patient comes, they are stable IOPs, but the field is progressing. And if you take the history, whether the patient is taking water on empty stomach, he will take, I am taking 1 liter in the every day of the morning. And during that time, the peak will be there and the progression of the field. Once they ask, along with the history of beta blockers, history of asthma, you ask again the history of water drinking. This is also very, very important. This patient actually, I thought, this patient, you see, the probability plots, they look similar. They are stable. And if you see the grayscale, there is a progression. This patient, 2003, 2006, I missed progression, 7 to 12, because we were asked to put a teacup on the grayscale. So grayscale gives you huge information. Even in my first edition book, I wrote to put a teacup on the grayscale, and only grayscale it gives beauty to the single analysis printout. But this patient I learned by seeing a probability plot, because any loss of retinal sensitivity more than 8 dB is a black square. So further loss will not be changed. So they are all black squares. If you see, minus 20 raw data is also black square, and absolute scotoma is also black square. So by seeing a black square, we cannot tell what is the exact depth of the field at that point. Only you have to see either raw data or total deviation plot. To some extent, the grayscale will give you, the dark shade will give you, the loss is severe. So once this patient I followed till now, almost now stable. Where I missed, but afterwards it was stable. I did trabeculectomy in this patient, and whatever I missed in the 3 visits in the first 3 years, but I retained the same field defect now without any progression. I told you this one. See, glaucomas sometimes they may be stable in 24-2, but they progressed 2016 to 2017. See, they progressed 2016. Actually, the glaucomas here it is a multicentric origin. Here it is. If you miss the multicentric origin, it's likely to, because this IOP, the multicentric, the scotomas appearing within 10 degrees glaucomas, they require very low pressure target IOPs. This IOP, what I targeted, is enough for 24-2, but not enough for 10-2. So in this patient at this stage, I did actually trabeculectomy, and this fields remains stable. In this case also, you see, they are stable in 24-2. They are progressive from this, but here they are stable. Why they actually this thing, these triangle, half triangle, unfilled triangle only became because once a black square appears, there won't be any change. So these symbols are there. They tell that there is a change in that area. If you label that, see, if they are dark means, because in that area, it is giving an indication that the change in the depth of the field effect. For that purpose, because any black square more than 8 dB is represented by a black square, further loss will not be known. By giving these symbols, actually we know the loss is occurring, further loss is occurring, more severe loss and no loss, loss in 2 consecutive points or something is given in this. Dot, a single solid dot indicates point not changing by significant. A small open triangle identifies a degree of deterioration expected less than 5% of the time at that location in a stable glaucoma patient, p-value 0.5%. So by these, the probability, the progression analysis probability plot, we will see this plot indicating whether there is a any change in those particular points in areas. Because if you see a black total deviation probability or pattern deviation black squares, we don't know the progression. Single dot, small dot. That is how the symbols came. This is actually GPA. GPA, I don't consider GPA because GPA is absent in 10-2. We don't know the progression in 10-2. It only holds good for the glaucoma starting outside 10 degrees and periphery outside 10 degrees. For those cases, only visual field index VFI with GPA holds good. And the other AC, they don't know. Thank you. Okay. Ajit Babu Garu?
Yeah. Dr. Savichachi?
Are you happy or any doubts? But I'm happy. They interpreted the field well.
Yeah.
Something, and really good. I hope now with this background,
I think only 2 people participated. Rest of them are in dark. They are not on video. That is the problem. We could not ask them.
You can teach them.
Obviously.
That is correct, but why we cannot understand why they are showing their face. Because it is a good opportunity for them to discuss. And I thank Dr. Reddy for his extensive discussion on this single field and also progression analysis. Now, I think the way you interpreted the indications of 10-2, because I have never had that in so vividly described and explained. Because many a time we take the single printout as the sole indication or sole criteria for diagnosing glaucoma. So I thank you very much. I thank Dr. Ajit Babu for taking so much of interest for the learning of our residents. And I thank all the residents who have participated and who have not participated and also only listened to the talk. Thank you very much, sir. So any questions or any discussions?
You have to go through my book. Everything is written in my book. What all is there in the book, I only told you.
Okay, sir.
No, but okay, I'm happy. At least the students, they interpreted well. You start with the probability plot and you see the extent, the location, and that's a progression. Then you go to the raw data and total deviation numerical plot, see the exact retinal sensitivity and the exact depth of the scotoma. Then you go to the 16 points within 10 degrees of 24-2 and what is, then you compare the fundus photograph and whether indication for 10-2, you see the grayscale, dark area, you see the probability plot, the black square, and if needed, you go for OCT. Never say that OCT is superior or OCT inferior, fields inferior, because OCT cannot give so much information what the visual field gives you. But once you OCT also, if you interpret OCT in micron levels, the same like visual fields, it gives information. Nobody, they see red zone and they say green zone normal. No. If you both may be green, but one may be 70 microns and one may be 90 microns. It is just like a black square. Black square -8 is also black square and -30 is also black square. So by seeing a black square, we should not say that both are same. Just like seeing a green shade in a OCT, we can't comment what is the micron because 90 is also green and 80 is also green. But there is a loss of 10 microns. But both are represented by green shades. You always go from the micron. What is the real thickness in microns? Both are complementary to each other, especially ganglions and analysis in 10-2. It gives very early.
Even the importance of grayscale also you explained well, because many times I have heard that grayscale is not that important.
Grayscale is very, very important. Only thing is central 10 degree, losing the brightness, that is the most catching point. Losing brightness in the central 10 degrees area is abnormal. Even though the shade may be better than the periphery, still it is abnormal. because minus 40 to minus 30, 10 dB loss is there. Still the shade may be better than the peripheral shade. Peripheral shade is 28 dB. So, but the losing the brightness in the central 10 degree area, that actually make you think that something is going wrong in the within 10 degrees.
So thank you very much, sir. But I think this needs another repetition after 6 to 8 months.
Dr. Tudu, do you want to say anything?
Yes, sir. Sir, I wanted to know when the scotoma is affecting 1 or 2 quadrant of the fixation, what is the incidence of this wipeout in your experience?
No, actually wipeout I hardly see.
Yes.
Ripping out, it is during progression they lose. Even during after during my surgery in an advanced cases, they retain the vision.
Okay.
No, Dr. Reddy, the wipeout occurs certain times during the surgery, no?
Actually, we thought, sir, and especially within macular program, if they within 1 degree, if it is healthy, 1 degree or within 3 degrees, the wiping out chances is very less. But we are always afraid because it can happen to any patient. That is why we always tell to the patient guarded prognosis. It can happen in any patient. It all depends upon the retinal sensitivity at that point is 40. Then okay, the 1 degree point. But always any within 3 degrees point is involved. We always say guarded prognosis.
Okay, sir.
We do not know what happens. Sometimes hypotension, the surgery the tension may become slow. Trabeclectomy, doing surgery is easy. Post-operative management is difficult. We cannot predict. Especially in these patients, I don't aim for gross low IOP. Trabeclectomy I do to decrease. Again, added to the drops. If they come to desired level, it is okay. I don't aim for too much. I don't do deep trabectomy too much. Ask him bigger size. Because if the hypotony, then if it happens, we lose the existing vision. We have to plan the surgery in such a way. How is the vision retained and not? And finally, it depends on the luck of the patient.
Dr. Maitri, you want to comment anything?
Thank you so much. It is a really excellent one. So I've given my comment that nothing can be better than this. It has actually so many points. What he made it was actually hammered on my points also. So
madam, actually, we talked in the conference, no, GSI?
Yes, sir. Yes, sir.
I asked your number, cell number. Can you tell, madam, your number?
Yes, sir.
It must be there, no?
Yeah.
In our group.
I'll send it personally.
No, you tell your number, madam.
98302, sir.
98.
Everyone is noting down now.
302
13 902.
90. Because that time you asked me,
yes, sir.
Discussion was going on.
That was the absolute clear idea. I wanted to share it with the people who are attending this conference.
Just I entered, madam, that room.
Yes, sir. So that's why I saw you. So I told them no one can give you the better concept except you. That's why I asked you.
Thank you, madam.
Clear message was given to the audience. Thank you so much, sir.
Any other comments from other moderators? Yeah.
Hello, sir. This is Shahinur.
Yeah, please.
Yeah. Sir, regarding the macular wipeout that you had discussed, I would just like to share my experience. I have not seen any wipeout as such, but there have been 2 patients on follow-up, the ones which we suspect or we fear that there may be a macular wipeout. So post-operatively, they have been fine, but after 2-3 years, gradually the vision came down, say, from 624 to counting fingers 2 meters. So when I saw the patient after the workup, I was really very scared that vision suddenly after 2 years now the patient is having counting fingers 2 meters. But surprisingly, the patient herself did not notice any difference in the drop of vision. But clearly in a span of 6 months from her last visit, the vision had dropped from 624 to CF 2 meters. So I assume that probably the field is so reduced in these patients that a further decline is not really noticeable to them.
Dr. Reddy?
No, sir. So, madam, your surgery actually prolonged actually. Otherwise, the deterioration might have occurred earlier than expected. This thing.
Okay. Yeah. I mean, the field is actually so much worse. I mean, so deteriorated that the patient does not feel the drop. What we
if they have the central vision, already they are accustomed to the tubular vision. Even the tubular vision reduced to some extent, they will not notice because they will be happy if they have working, just going to the bathroom and taking the food. If that vision is enough for them. The field of vision may be reduced, but still they will have that vision for working. But as you told me, the surgery actually prolonged his existing vision. Actually.
No, but see, Dr. Reddy, if we are recording certain 624 or something and suddenly counting fingers, do you say there is a worsening of the point?
No, worsening will be, patient will be definitely will be appreciated. Most probably the field of vision might have reduced. The central visual acuity of 1 point must be good. In this case, some of the cases, even the vision, the foveal sensory 37, the 35, and the peripheral, they are lost. The field of vision is reduced. Most probably, at that point, she had a good vision. She is able to see whatever the tubular vision she had.
Yes, peripheral vision was there. So, but the central field was gone. So probably she was managing with the peripheral vision only. But I don't know. But I asked specifically to the patient because I was myself scared. From 624, it came to CF 2 meters. But patient had no complaint. And there's nothing else to explain the drop in the vision.
What about the other eye vision?
Other eye vision, ma'am, she had advanced glaucoma, but that eye, I can't remember now exactly, but she had useful vision in that.
I think she was managing with that eye. That's why was not able to plan anything.
The first slide I told you, always we should have the both eyes. Because this eye, scotoma will be seen by the other eye.
Okay.
And I told you the upper nasal scotoma and the other eye will be seen unless otherwise in that lower this central area is involved in the other eye, then she will have absolute scotoma. So always you see the other eye scotoma, one eye scotoma and corresponding that scotoma last which is seen by the other eye, and if that area is now scotoma is appearing, that eye should be treated very aggressively to stop the scotoma appear in that area which is seeing the scotoma produced by the other eye. That is also an indication for extra aggressive treatment of the other eye. Therefore, always you see and correlate both eye fields. What is the field in one eye? What is the field in the other eye? And especially when it is, I told you, in glaucoma suspect, hold both eyes, one eye with the right hand and one eye with the left hand, and compare.
If the patient is one-eyed, what will you do, Dr. Jia?
One eye means you hold only that field.
Yeah, in that case, if there is a drop, do you increase the
aggressive? No, any glaucoma advanced, we should be an aggressive, and you should not wait to do surgery till the last. You have to do the surgery early. You need not wait till the last when you know that he is going to have a central vision threatened. You have to go for the surgery.
I think Dr. Savichaji, you can request the intro to do the play their video, and then we can say vote of thanks.
Thank you, sir. Thank you very much. And Todd, you can play your video. Anyone?
Hello, Reddy.
Prasad?
I have got one doubt. For example, in advanced glaucoma, do you advise say a routine trab or phaco trab? Because I feel if you do phaco trab, see the more pressure that is maintained throughout the surgery may knock out even the residual vision. So whether our manual trab is better or phaco trab is better? What do you advise?
Actually, Prasad, I stopped doing combined for the last 4 years. I am not doing combined. Any glaucoma, I first do cataract because now clear cornea. Clear cornea phaco, you remove the cataract first, and then if you need a put on treatment, if needed, you go for trab. Because once you combined, it is most unpredictable. Hypotony, whatever the macular edema, the wipe up may be still more worsening and all. I stopped doing phaco, that is combined after clear corneal phaco.
No, not only combined. What I am asking is, in advanced glaucomas, is it advisable to do phaco, or is it advisable to do a manual SSCS?
No. Phaco only.
More IOP may be there, no?
No. You have to do control day. Routinely, I am doing only phaco in even advanced. And only thing is, we see that the pressure should not raise.
Okay, right.
Yeah, not only that, if between SSCS and phaco, the intraocular pressure will be more stable in phaco rather than SSCS. It's always better to be a stable intraocular pressure even during the surgery.
SSC is more dangerous.
Yeah. Okay, maybe Savichaji, we can go to the entered.
Please stop sharing, sir. Dr. Reddy, sir.
Dr. Reddy, please stop sharing your screen.
Wait, how to stop? Good.
So any presentation from Anton?
Yeah, I'll play the EIZOC. Just
Thank you very much. I profusely thank Dr. Reddy for his extensive discussion on this visual field and interpretation of automated experiment. I thank Dr. Ajit Babu Maji, our mentor of this program, for taking so much of interest. Thank all the participants, discussions, everybody who are listening to this program. Thank you all. Thank you very much. I thank Mentor also for their volunteer support. Thank you all. Good night.
Good night. Okay, thank you, Reddy, for your contributions.
Good night, sir. Thank you. Thank you all.
Okay. Good night.
Good night. Good night.